Welcome to the THOR Table of Knowledge podcast, where we dive deep into the groundbreaking world of trauma care, hemostasis, and oxygenation research. A special thank you to our sponsor, Velico, for their support. Velico is revolutionizing trauma care with their innovative frontline ODP spray-dried plasma system, with the goal of empowering blood centers worldwide to produce dried plasma for transfusions.
Hi, I want to introduce Dr. Christine Leeper, who's going to be speaking with us today in the THOR Table of Knowledge podcast on pediatric trauma and hemostatic resuscitation principles. Christine, clearly this is a big problem in pediatric care since trauma is the most common cause of deaths for children from 1 to 18 years of age. And now recently, gunshot wounds have become the most frequent cause of death within the pediatric population. So what do we need to do as a community to help improve outcomes for children with severe traumatic bleeding?
Yeah, I think, that data was really a call to action. And, there was a consensus conference recently which highlighted the need for really evidence-based practice in pediatric trauma, which we don't currently have. Despite the magnitude of this problem, many providers are using, guidelines or algorithms that were initially developed in adults and were specific to the pediatric population. And, we know that there are differences between children and adults. And so a one-size-fits-all strategy is really not the best.
So what are some of those differences?
Yeah, children have hemostatic factors and activity that varies across their development and from age 0 to age 18. They don't respond in the same way to interventions. They have anatomic and physiologic differences. So, truly they can't be assumed to be the same.
Right. That's a really good point. What are some of the gaps in the hemostatic resuscitation therapies that should be prioritized? What should we figure out first if they work in children or not?
Yeah, from my standpoint, transfusion and figuring out the optimal blood product resuscitation is huge. We are learning a little bit more about, whole blood and ratios of components, specifically in children, but haven't quite determined what the optimal product is, what the optimal timing is.
And don't you think part of that is because we don't really understand why children are bleeding in the first place? I mean, the term trauma-induced coagulopathy has been coined to kind of summarize not only the coagulopathy that occurs with severe bleeding, but the shock, the endotheliopathy, and the immune dysfunction. So what can we do to most efficiently characterize or define trauma-induced coagulopathy in children?
Yeah, it's a big catch-all term that really encompasses a lot of different pathways and mechanisms. And, we have been learning a little bit more, but, these new technologies that we have now, multi-omics platforms, can really use a very small amount of blood, which is, as you know, important in the pediatric population to try to minimize blood draws and give us a tremendous wealth of information. Which is actually something we're incorporating in our MADIC-2 trial, which is upcoming. So hopefully that'll give us a lot more information about, what some of the underlying processes are and, why certain children are responding to treatment while others are not.
Right. I was going to bring up the MADIC-2 trial, as you probably suspected. But before we do, let's talk a little bit more about tranexamic acid. I guess, for the audience that doesn't know, what is it? And what evidence is there for or against it in the pediatric population?
Yeah, tranexamic acid falls in the class of antifibrinolytic medications, although its exact mechanism is not entirely known. And there is great data from the CRASH series of trials in adults showing that in folks who are age greater than 18, that it really confers a survival advantage. The evidence is much less clear in children. There are 2 trials in military cohorts, small, each less than 100 patients, which show that there may be some survival advantage. But again, those are, from combat studies that don't always reflect the general pediatric cohort that we see here in the States. There's some safety data from other patient populations. So children who are having spine surgery, children with craniofacial abnormalities, and we're receiving doses that are a lot higher than what we would typically give in trauma, and there doesn't appear to be a safety signal, so that's reassuring.
Gotcha. And there's been some prospective observational data from the first MATIC study, right?
Yes.
That we've published together that indicates either Amicar, another antifibrinolytic, or tranexamic acid may improve survival, but not randomized data and not super strong evidence that should change practice in children. So MATIC-2 then is a trial that will be comparing whole blood to components as well as TXA versus placebo. Can you tell the audience maybe a little bit more detail about the trial and what it aims to be able to accomplish?
Yes. So this is a platform trial design, which enables us to look at different interventions simultaneously and really capitalize on all the investment and time and effort that folks are putting into standing up the trial. We'll be at 20 to 24 different sites in the United States, pediatric trauma centers, and enrolling severely injured children who are actively bleeding. And it will enable us to sort of compare not only those interventions individually, but also the combinations of treatments, which is really important because, often in a trial you're studying one thing at a time and, that's not how we treat patients. So we want to kind of figure out what's the best bundle of care.
Right. No, that makes a lot of sense. And luckily with the funding through BARDA, we have the opportunity to continue the trial in the platform design once these two interventions are assessed. If you got to pick yourself what those interventions would be that we study next in children, what would you want to do?
Yeah, I think there are so many opportunities on account of all the knowledge gaps. I think, looking at some of the different alternate transfusion products would be really interesting. Something like a freeze-dried plasma or, a fibrinogen concentrate. Looking at the different timing of administration, so potentially adding on a pre-hospital component or, moving the therapy closer to the time of injury would also be really exciting.
Really great ideas, and I completely agree. Although I think we're learning now from some recent trials, such as the Cryostat-2, the indication to give these products is real important to determine before you start a trial. The empiric use of these hemostatic adjuncts in a trial may lead to enrolling patients that may not benefit from the therapy. So then there's no chance of showing a difference between the products. So with that in mind, what would your idea be, or how would you design a trial to determine who should be getting these hemostatic adjuncts, fibrinogen, cryo, et cetera?
Yeah, I think, you really need to pick your inclusion and exclusion criteria carefully. Fortunately, the MATIC-2 trial design allows for sort of different inclusion and exclusion criteria based on the treatment arm to try to assess out, which is the best cohort to be enrolling for each individual therapy.
Are there specific assays that you think would be better than others to determine who needs a source of fibrinogen, a PCC, movement, or even, a lot of people are talking about calcium. Should calcium be measured, or should it be studied empirically?
Yeah, I think, we will need a little bit more data to sort of try to guide those, and having some of the preliminary studies being retrospective and even prospective observational really guides the future of the trial.
Agreed. So I know another passion of yours, or a trial that you want to get done, is to study the use of plasma for children with severe traumatic brain injury. So what's the rationale behind wanting to study plasma for children with brain injury?
Yeah, the data thus far in adults has shown that early or pre-hospital plasma confers a survival advantage, and pretty uniquely in the traumatic brain injury cohort. For children, the TBI is a tremendous source of morbidity and mortality, and there's not really been a resuscitative intervention that has been impactful as far as survival to date. So, sorting out when that patient first arrives, or even before they get to the hospital, is there something that we can do to, improve their chances of survival and even neurologic outcome?
Right. How would plasma work in this situation? What plasma, most people think about its hemostatic or clot forming capabilities. With TBI, would it just be that, or are there other mechanisms of action that could be in play?
Yeah, there certainly are. It's been proposed that plasma is a great resuscitator of the endothelium. I think our multi-omics analysis will be really helpful in understanding better what some of those phenotypes are of trauma-induced coagulopathy. And, we'll be able to look at polytrauma versus isolated traumatic brain injury and, try to figure some of that out in a little more detail.
Right. Yeah, I completely agree. I guess what else? Those are two very big projects, and with...
Is that not enough? That's what...
Well, you're a young physician. You got plenty of time left in your career. I guess long term, what are some of your other long-term goals, and what would you love to accomplish over time?
Yeah, I think bringing the therapeutics closest to the time of injury is going to be the next frontier for pediatric trauma. And already there are some different groups and organizations that are being really thoughtful and aggressive with their pre-hospital resuscitation, not only of adults but also of children. And I think that is probably where we'll see a lot of the field moving, hopefully, in the next decade or so.
Right. So last question, and it goes back to the MEDIC-2 trial. One of the difficulties we had in designing the trial was how to treat girls who had severe bleeding. And the issue surrounds the fact that whole blood is mainly only available as an Rh positive product. And if that was given to a girl who was Rh negative, that could cause severe complications for her long term if she ever became pregnant. So I guess in the trial we've come up with a way to deal with it. But I guess just what are your thoughts on the topic, and did we come up with the right approach in the trial?
Well, it's a very complex topic, and folks have some strong opinions. In my opinion, we should be treating girls who are bleeding with the treatment that we think will offer them the best chance of survival. And in this case, we have some data to suggest that that's whole blood as compared to components. Again, we're doing this trial to get some additional definitive data. But I think, for folks who are treating the patient in front of them, they want to be able to choose what is the most efficacious treatment. If that girl has the good fortune to survive and then, hits all the Swiss cheese holes aligned such that she develops, an alloimmunization, then goes on to be pregnant, and her partner then is Rh positive, and, she develops a sufficient antibody titer. There's really a lot that kind of has to align. Then we want to make sure that we are kind of still providing the best care for that patient and for her future child by providing counseling and education and support. And so that's sort of the strategy that we have taken in the trial, is to make sure that we are appropriately treating folks for the conditions that they may or may not develop.
Right. Well, thanks, Christine. This has been a fascinating conversation, as always. And I just want to thank you for participating in the THOR Table of Knowledge podcast.
Nice talking to you in Miami.
Skull.
That's a wrap for this episode of the THOR Table of Knowledge podcast. A big thank you to our sponsor, Velico, for supporting the advancement of trauma care. Their frontline ODP spray-dried plasma system is paving the way for blood centers globally to produce potentially life-saving plasma for transfusions. Check out our website, www.thornetwork.com, for more podcasts, and join us next time as we continue to explore the cutting-edge science of trauma, hemostasis, and oxygenation. Until then, stay safe and stay informed.